1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, usually when we approach a medical diagnosis, there's this expectation of like mechanical precision.
Right, yeah. Like it's a math problem.
Exactly. I mean, if a patient breaks their arm, the x-ray shows that jagged white line, you know.
Oh.
The orthopedic surgeon points to it, and that's just the reality. It's binary.
It's either broken or it's not.
Yeah. And it's a very comforting way to practice medicine because the enemy is completely visible.
It definitely allows for very neat categorization. You know, you see the problem, you fix the problem.
But the second you step into the world of neurovascular trauma, that x-ray machine just shatters.
Yeah.
The diagnostic landscape gets entirely murky, and the timeline shrinks down to almost nothing.
Oh, absolutely nothing.
So today, you are stepping directly into the high-stakes, rapid-fire environment of the intensive care unit. For this deep dive, you are putting on the scrubs of an elite ICU nurse, and you're going to learn how to think exactly like an intensivist who is facing down a brain attack.
Which, by the way, is a critical shift in terminology that we have to address immediately.
Yeah, let's get into that, because we didn't used to call it that.
No, we didn't. For decades, the medical community used the term CVA, right? Cerebrovascular accident.
Right.
But, I mean, think about the psychology of the word accident. It implies a passive event, like something unfortunate that occurred in the past, and now you are just managing the aftermath.
Oh, I see. Like a car crash that's already over.
Exactly.
Mm.
A brain attack implies an active, ongoing emergency. It mirrors the urgency of a heart attack because physiologically, they are identical mechanisms playing out in different organs.
Blood flow gets interrupted, right?
Yeah, blood flow is interrupted, the tissue is starved of oxygen, and you have this terrifyingly brief window before irreversible cellular death just cascades through the tissue.
I really want to focus on that window for a second because with cardiac tissue, we know we have a little bit of grace time, you know, before the myocardium truly dies.
Yeah, the heart stuff.
But the brain is incredibly greedy when it comes to oxygen and glucose. So how short is this window, actually?
5 minutes.
Wait, just 5 minutes?
Okay. That is the absolute limit. If blood flow to a section of the brain is completely severed, the neurologic metabolism alters within 30 seconds.
30 seconds, wow.
Yeah. Within 2 minutes, metabolic activity halts entirely. And by the 5-minute mark, you cross the threshold into permanent, irreversible cell death.
Which, I mean, that begs the question, right? If the window is only 5 minutes, why doesn't a stroke just wipe out the entire brain by the time the ambulance even arrives?
Well, because the brain is an architectural marvel. It doesn't rely on just a single isolated pipeline.
It has backups.
Huge backups. It relies heavily on collateral circulation. At the base of the brain, you have the circle of Willis, which is this brilliant vascular roundabout that connects the anterior and posterior circulations.
So it can detour the blood.
Exactly. When a major artery is blocked, the brain immediately attempts to reroute blood flow through these collateral pathways to bypass the occlusion, you know, to keep the downstream tissue alive.
It's buying you time.
Right, it buys you time. But those collateral vessels are tiny. They offer high resistance, so they cannot sustain the tissue indefinitely.
So we had this massive ticking clock. And as the ICU nurse receiving this patient, your entire treatment paradigm really hinges on one crucial fork in the road.
The biggest fork in the road.
You are dealing with either a blocked pipe or a burst pipe, ischemic or hemorrhagic. Yep. And if you mix up the pathways, like if you apply the blocked pipe treatment to the burst pipe patient, you will kill them.
It is exactly that black and white. So, I mean, we have to start by dominating the most common scenario, right? The ischemic stroke, the blocked pipe.
Let's do the 80-20 on that. How common is it?
It accounts for 87% of all strokes.
Almost 9 out of 10.
Yeah. And within this category, you are looking at 2 distinct mechanisms of blockage. The first one is thrombotic.
Which is basically a local plumbing issue.
Exactly. A thrombotic stroke is the gradual, insidious narrowing of an artery. It's almost always driven by atherosclerotic plaque buildup.
So it's a rusty pipe just slowly occluding over decades.
Right. And because the narrowing is so gradual, the actual final blockage often occurs during sleep or rest when blood pressure naturally dips and flow becomes sluggish.
Oh, so the patient just wakes up with a deficit?
Yeah, they wake up paralyzed. And clinically, these symptoms might stutter or present with a stepwise progression over a few hours.
So the profile for a thrombotic stroke is someone with a long history of hypertension, severe diabetes, hyperlipidemia. Like, their vascular endothelium has been taking a beating for years.
Precisely. Their vessels are damaged, they're rigid, and they're narrowed.
But then you have the embolic stroke, which presents entirely differently. I mean, this isn't a gradual clogging. This is more like a boulder rolling down a hill and slamming into a narrow canyon.
Sudden, violent onset. In an embolic stroke, the clot forms somewhere else in the body, breaks loose, travels up the carotid arteries, and lodges in a cerebral vessel.
Usually the middle cerebral artery, right?
Yeah, mostly the MCA, simply because it's a direct, wide pathway. And the absolute biggest culprit here, the engine that's creating these traveling clots, is atrial fibrillation.
Because in AFib, the atria aren't producing a coordinated, forceful squeeze. They're just kind of quivering.
Right. And when blood doesn't move efficiently, it pools. When blood pools, it clots.
So a tiny clot forms in the left atrial appendage.
Yep. And then the heart suddenly converts to a normal rhythm or just manages a strong enough contraction, and it pumps that fresh clot straight into the systemic circulation. Bam! Instant occlusion in the brain.
Before we get into the whole cascade of what happens when that clot hits, I really want to clarify something that drives me crazy in popular media. The term mini stroke.
Oh, yeah, that's a terrible term.
Right. People use it to describe a TIA, a transient ischemic attack, and they treat it like getting a mild sunburn. They just brush it off.
Brushing off a TIA is a fatal error. A TIA is not a mini stroke, it is the ultimate warning shot.
So what's actually happening physiologically?
Well, the occlusion occurs, the downstream tissue becomes profoundly ischemic, and the patient develops obvious neurological deficits, slurred speech, unilateral weakness.
But then it goes away.
Yeah, either through intrinsic clot dissolving mechanisms or a shift in collateral flow, the blockage clears before that 5-minute threshold of infarction is reached. So the symptoms resolve completely, usually in under an hour.
So the ischemia happens, but the actual tissue death doesn't.
Correct. But here is the critical intensivist thinking. You have absolutely no way of knowing if that temporary clot was an isolated event or if it was just the opening act for a massive, catastrophic occlusion that's coming later today.
Which is why we don't just send them home from the ER with a pat on the back. We admit them and run the ABCD2 score. Can you explain the mechanics of that score? Like, why do these specific factors matter?
So the ABCD2 score predicts the exact risk of a patient having a full-blown stroke within the next 48 hours.
Okay, so what does it look at?
It looks at age over 60 because vascular compliance drops with age, blood pressure over 1490 because hypertension creates the shear stress that ruptures plaques.
Got it. What about the C?
Clinical features, specifically unilateral weakness or isolated speech impairment, because these indicate major vascular territories are threatened. Then duration of symptoms, the longer the TIA lasts, the closer they were to permanent infarction.
And the D is diabetes.
Yep, diabetes.
Why is diabetes specifically singled out there?
Because chronic hyperglycemia just destroys the microvasculature. It impairs the very collateral vessels the brain relies on to survive an occlusion.
Oh, wow.
Right, so if a diabetic patient has a TIA, their backup system is already compromised. If they score high on the ABCD2, they are getting admitted to the stroke unit for aggressive monitoring.
You mentioned blood pressure as a scoring metric, and it is the single most important modifiable risk factor for strokes across the board. Like, if you aggressively manage hypertension, you can slash stroke risk by up to 50%.
It's massive.
But this isn't distributed evenly across the population, is it?
Not even close. You really have to view stroke pathology through the lens of health equity. Black populations in the United States have twice the incidence of first-time strokes compared to any other demographic.
Twice the incidence.
And they suffer double the mortality rate. This isn't some arbitrary genetic lottery, you know.
Yeah.
It is intrinsically linked to systemic disparities in healthcare access, chronic stress loads, and the resulting disproportionate rates of uncontrolled hypertension and diabetes.
So when the system fails to manage blood pressure at the primary care level, the ICU inherits the catastrophic result.
Exactly.
Okay, let's step into the ICU. The patient has arrived. The trigger has occurred. The middle cerebral artery is blocked. We know the window is 5 minutes. What is actually happening at the cellular level during that countdown? Because the brain isn't just passively waiting to die, right?
No, it is fighting violently to survive. The immediate physiologic change is ischemia, the sudden loss of oxygen and glucose.
And without oxygen.
Without oxygen, the neurons cannot produce ATP, cellular energy. Without ATP, the sodium-potassium pumps on the cell membrane instantly fail.
And those pumps are what keep the electrical balance of the cell.
Exactly. When they fail, sodium rushes into the cell. Water always follows sodium, right? So the neuron begins to swell massively.
Okay, so the cells are swelling.
And simultaneously, calcium floods into the cell, which triggers a massive release of glutamate. That's an excitatory neurotransmitter.
Which causes excitotoxicity.
Yes, the neurons literally fire themselves to death.
Man. So while the cells are swelling and firing, what is the macrovascular system doing to try and help?
It's attempting rescue. Cerebral autoregulation kicks into overdrive. The blood vessels downstream of the clot dilate to their absolute maximum diameter, dropping vascular resistance to near zero.
Desperately trying to siphon any available blood from the collateral pathways of the circle of Willis.
Right. But if the primary clot is large enough and it doesn't move, compensation fails. Decompensation takes over.
And what does decompensation look like?
The collateral flow just isn't enough. The swollen neurons burst. That cell death necrosis triggers a massive local inflammatory response. White blood cells rush in, the blood-brain barrier breaks down, and fluid leaks directly into the brain tissue.
This is cerebral edema.
Exactly. The brain is now swelling inside a rigid, unforgiving skull.
So as the nurse at the bedside, how does that cellular explosion translate into clinical findings? What are you actually seeing?
Well, the most immediate sign is contralateral motor deficits.
Meaning the opposite side.
Right. If the massive clot is in the right hemisphere of the brain, you're going to see paralysis or profound weakness on the left side of the patient's body.
Let's lock down the anatomy on that really quick. Why contralateral? Like, why doesn't right brain damage just affect the right side of the body?
It all comes down to the pyramidal pathway, the primary motor tract. The nerve fibers that control voluntary movement originate in the motor cortex of the brain. They travel straight down through the internal capsule and into the brainstem.
Okay, following you so far.
Oh, but right at the bottom of the brainstem, in the medulla oblongata, the fibers decussate.
They physically cross over.
Yes, they cross over to the opposite side of the spinal cord. So a lesion in the right hemisphere cuts the signal before it crosses, manifesting as a deficit on the left side of the body.
So you see the classic hemiparesis, the facial droop, and if the dominant hemisphere is hit, the sudden loss of speech.
Exactly, which is the FAST assessment, face drooping, arm weakness, speech difficulties, time to call a code stroke.
But FAST is really for the general public and the triage desk. In the ICU, your focused assessment is the NIH Stroke Scale, the NIHSS.
The NIHSS is your primary diagnostic tool at the bedside. It is a highly specific 15-item neurological exam scoring the patient from 0 to 42, and higher is worse.
What exactly is it assessing?
It assesses level of consciousness, gaze, visual fields, facial palsy, motor function in all 4 limbs, ataxia, sensory loss, language, dysarthria, and inattention or neglect.
Why is this specific scale so critical? Like, why not just use a standard Glasgow coma scale?
Because a GCS just tells you if they're awake. The NIHSS tells you exactly what vascular territory is dying.
Oh, that makes sense.
Yeah, if their gaze is forced to the left and they have right-sided weakness, the NIHSS score immediately tells the intensivist that the left middle cerebral artery is likely occluded.
And it gives you a baseline.
Yes. Getting an accurate baseline NIHSS the exact minute they hit the stretcher is the only way you can evaluate if your interventions are working. If they come in as an 18 and 2 hours later they are 22, your treatment has failed and the stroke is expanding.
Speaking of things expanding, I want to talk about level of consciousness, or LOC, because in a pure ischemic stroke, the patient is usually wide awake, right? I mean, they might be paralyzed on one side and unable to speak, but their eyes are open.
Yes, initially. Unless the clot directly hits the brainstem, which controls wakefulness, a cortical ischemic stroke does not immediately drop the level of consciousness.
And this is a massive bedside trap for nurses, isn't it?
Huge trap. Never, ever assume a neuropatient is just tired or sleeping it off. If a patient with an ischemic stroke starts becoming lethargic, difficult to rouse or drops their GCS 24 to 72 hours after admission, it is a 4-alarm fire.
Because that means the cerebral edema we talked about has peaked.
Exactly. The brain tissue has swollen so much that it has literally run out of room in the skull. The intracranial pressure is rising rapidly, and the swelling hemisphere is physically pushing across the midline and pressing down on the brainstem.
A dropping LOC means the brain is beginning to herniate.
It's herniating, yes.
Okay, let's back up to the moment they arrive. We have a suspected ischemic stroke. We need diagnostics. The absolute highest yield test, the one that takes precedence over everything else, is a non-contrast CT of the head.
Always first.
And I have to push back here because this seems totally counterintuitive to a lot of people. If we are hunting for a clot, a blockage inside a vessel, wouldn't we want to inject IV contrast dye to light up the arterial tree and show us exactly where the blockage is?
That is the most common logical fallacy novice clinicians make. When that patient first hits the scanner, our primary goal is not to find the clot.
It's not.
No. Our singular life or death goal is to find blood. We must unequivocally rule out a hemorrhagic stroke.
Because contrast dye on a CT scan looks bright white. And blood on a CT scan also looks bright white.
Exactly. Their radiodensities are nearly identical. If you push IV contrast and it leaks into the brain parenchyma, the entire scan lights up white. You will have absolutely no idea if you are looking at contrast dye or an active intracerebral hemorrhage.
And why does this matter so much?
Because the treatment for an ischemic stroke is the aggressive administration of systemic thrombolytics, massive, powerful clot busters. If you administer a thrombolytic to a patient who is actively bleeding into their brain, they will hemorrhage catastrophically and die right in front of you.
So a non-contrast CT is always first. You prove there is no blood, then you can proceed with the ischemic pathway.
Yes, that makes perfect sense. The non-contrast CT is the gatekeeper.
What else were we checking immediately?
A stat finger-sticks blood glucose. The brain requires a constant, massive supply of glucose. Severe hypoglycemia will cause localized metabolic failure that perfectly mimics an acute stroke, complete with unilateral weakness, aphasia, and facial droop.
So you have to rule out a blood sugar of 30 before you assume it's a clot.
Exactly. You also need a baseline EKG, specifically hunting for atrial fibrillation to confirm if this was an embolic event.
Let's translate this into the bedside workflow. If you are assessing this patient, the single most critical piece of historical data you must extract from the family or EMS is the exact time of symptom onset.
Or, if they woke up with the symptoms, the time they were last known well. The time of onset is the holy grail.
Why is it so rigid?
Every single pharmacological intervention we have hinges on that precise timestamp. If you don't know when it started, your hands are tied.
So your primary nursing diagnosis, though we don't say it aloud at the bedside, is ineffective cerebral tissue perfusion. And your planning goal is aggressive. Door-to-needle time under 60 minutes.
From the second the ambulance wheels cross the threshold of the emergency department to the exact second the clot-busting drug enters their vein, you have 1 hour.
That includes the physician assessment, the NIH the CT scan, the lab results, and mixing the drug.
It requires a perfectly choreographed team.
So let's talk about the priority sequence of nursing actions. Rank the interventions. Imagine standing at the bedside.
First priority, airway and breathing. Ensure their oxygen saturation is over 95%. Do not hyperoxygenate them if they don't need it, as excess oxygen can generate free radicals in ischemic tissue, but prevent hypoxia at all costs.
And keep them MTO, right?
Crucially, keep the patient strictly NPO, nothing by mouth. Their bulbar muscles, the ones controlling swallowing, and the gag reflex are likely compromised. If you give them a sip of water or an oral medication, they will aspirate it straight into their lungs.
Aspiration pneumonia is the most common preventable complication in stroke care.
Yes, it happens way too often.
Next priority.
The stat non-contrast CT and the blood glucose check. While they are rolling to the scanner, you are establishing at least 2 large bore IVs. You need reliable access.
Then what?
Then you determine eligibility for our heavy artillery. TPA, tissue plasminogen activator, also known as alteplase.
Walk me through the mechanism of TPA. How does it actually clear the pipe?
It is a profound fibrinolytic. A blood clot is held together by a sturdy mesh of protein called fibrin. TPA's mechanism of action is to bind directly to that fibrin mesh and convert a circulating protein called plasminogen into its active form, plasmin.
And plasmin does what?
Plasmin is an aggressive enzyme that essentially acts like molecular scissors. It chops up the fibrin cross-links, literally dissolving the architectural structure of the clot and restoring blood flow to the starving penumbra.
But it comes with a massive dangerous catch. What are the strict contraindications for TPA?
Well, the time window is absolute. It must be administered within 3 to 4.5 hours of the exact symptom onset.
Why that specific cutoff? What happens at hour 5?
By hour 5, the ischemia has progressed to irreversible infarction. The brain tissue is dead, and more importantly, the endothelial walls of the blood vessels supplying that dead tissue has become profoundly weak, necrotic, and friable.
So if you blast them with TPA?
If you administer TPA at hour 5, you dissolve the clot, and suddenly a massive surge of high-pressure arterial blood blasts into those dead, fragile vessels. They will instantly rupture.
You will turn a localized ischemic stroke into a massive, uncontrolled hemorrhagic conversion.
Exactly. It's devastating.
What are the other red lights for TPA?
Any history that suggests an active or recent bleeding risk, a recent GI bleed, major surgery, or severe head trauma within the last 14 days, a history of any prior hemorrhagic stroke, or current use of strong anticoagulants with elevated clotting times.
And the vital sign monitoring for TPA is arguably the most stressful part of the ICU nurse's job, specifically the blood pressure parameters.
It is a high-wire act. Before you even push the bolus of TPA, the patient's blood pressure must be strictly lowered to less than 185 over 110. If it is 186, you cannot push the drug.
And after.
During the infusion and for 24 solid hours afterward, you must maintain the blood pressure below 180 over 105.
Why so strict?
Because TPA systemicizes. It thins the blood everywhere. If the systemic pressure is too high, it will blow out the capillary beds in the brain and cause a hemorrhage.
How do you keep it down?
We manage this using rapid-acting, titratable IV antihypertensives, usually a labetalol or a nicardipine drip. You are adjusting the drip minute by minute, responding to the arterial line, keeping them right in that safe zone.
Now, what about the most famous cardiac drug in the world? Everyone knows that if you are having a heart attack, you chew an aspirin immediately. If a brain attack is the same mechanism, shouldn't I load them up with aspirin the second they hit the door?
Absolutely not. This is a classic exam trap and a fatal bedside error. Yes. If the patient is a candidate for TPA, you never give aspirin right away. You must wait a full 24 to 48 hours after the TPA infusion is complete, and usually after a follow-up CT scan confirms there is no bleeding.
Because if you mix them...
If you stack TPA and aspirin on day 1, the synergistic antiplatelet and fibrinolytic effects will almost guarantee a fatal intracranial hemorrhage.
Okay, so what if they wake up with the stroke, so the time of onset is unknown, meaning TPA is off the table? Or what if the clot is just too massive for the drug to dissolve? Are they just out of luck?
No, the technology has advanced incredibly.
Yeah.
We moved to endovascular stent retrievers or mechanical thrombectomy.
This is interventional radiology, right?
Yes, at its finest. The physician enters through the femoral artery in the groin, or increasingly the radial artery in the wrist. They thread a microcatheter all the way up through the aorta, up the carotid, and directly into the occluded cerebral artery.
And then what?
They deploy a tiny, self-expanding wire mesh net inside the clot to capture it, and then they physically pull the entire clot out of the brain.
That is incredible.
It is stunning to watch, and depending on perfusion imaging, it can sometimes be performed up to 24 hours after symptom onset in highly selected patients.
I want to pivot to hemodynamics because this is where the true intensivist thinking shines. We need to talk about carbon dioxide. Why does the ventilator setting or the patient's respiratory rate matter to their brain?
Because CO2 is a remarkably potent cerebral vasodilator.
So it opens the vessels.
Yes. If a patient's respiratory drive is depressed, say they are lethargic from the stroke, they won't blow off enough CO2. As CO2 accumulates in the blood, it signals the cerebral blood vessels to dilate widely. This massively increases the sheer volume of blood inside the skull.
And since the skull is a closed box,
The intracranial pressure spikes. In a brain that is already developing cerebral edema from an ischemic stroke, a high CO2 can push the ICP to lethal levels and trigger herniation. You must ensure they are ventilating adequately to keep their CO2 in a normal or even slightly low range.
all right, here's a concept that I want to push back on heavily. Permissive hypertension.
Yeah.
We just spent 10 minutes establishing that high blood pressure causes the endothelial damage that leads to strokes, and that we have to aggressively drop the pressure below 185 to give TPA. But the literature dictates that if the patient is not a candidate for TPA and they are not getting an intervention, we just let their blood pressure ride, sometimes up to 220 over 120.
Right.
How does that not violate every basic rule of cardiovascular medicine? Why would you purposefully let a stroke patient sit with a blood pressure of 210?
Because it is a desperate, brilliant physiological defense mechanism. You have to understand the anatomy of the stroke.
Okay, walk me through it.
The area of the brain directly supplied by the blocked artery is the core. It is dead. It is unsalvageable. But surrounding that dead core is a halo of tissue called the penumbra.
And the penumbra is?
The penumbra is ischemic, it is electrically silent, it is starving, but it is still structurally intact and alive.
Because it's getting that trickle of blood from the collateral vessels we talked about earlier.
Exactly. But remember, those collateral vessels are tiny alternative routes. They have incredibly high vascular resistance. So how does the body force blood through a tiny, high-resistance collateral network to save the dying penumbra?
It ramps up the pressure.
It ramps up the systemic pump. It jacks the blood pressure up to 210 to physically force perfusion into that starving tissue.
Oh, wow.
If you, as the clinician, blindly look at the monitor, panic at the number 210, and push IV labetalol to normalize their pressure to 120/80, you completely remove the driving pressure. You will instantly starve the penumbra, actively expand the size of the stroke, and permanently worsen the patient's paralysis.
So you just let it ride.
So unless the pressure exceeds 220/120, or they have another acute crisis like an aortic dissection, we practice permissive hypertension. We permit the high pressure because it is the only thing keeping the brain alive.
That is the essence of critical care. Understanding the why behind the abnormal vital sign. What about 5E fluids?
Avoid hypotonic fluids at all costs. Never hang D5W or half-normal saline.
Why not?
Hypotonic fluids lower the osmolarity of the blood. Because the brain cells are already damaged and starving, that free water will rapidly cross the blood-brain barrier, pull directly into the neurons, and massively exacerbate cerebral edema.
So what do you use?
You stick to isotonic normal saline to maintain intravascular volume without shifting water into the brain. And you must monitor their electrolytes closely, particularly for hyponatremia.
Because of SIEH?
Exactly. Stroke patients frequently develop SIADH syndrome of inappropriate antidiuretic hormone. They retain free water, which dilutes their serum sodium, further worsening cellular swelling.
Let's look at deterioration. As the nurse, you are doing hourly neurochecks. What is the subtle sign that things are going south?
The earliest sign of deterioration is always a change in the level of consciousness. Long before the pupil blows, the patient will become slightly more difficult to arouse. Their responses will slow down. They might lose their gag reflex.
If you see a previously alert patient drifting into a stupor.
The cerebral edema is expanding and compressing the reticular activating system in the brainstem.
And escalation. When do you call the provider versus calling a rapid response?
You are notifying the provider for trend changes. If the blood pressure starts creeping up to 182, 183 during a TPA infusion, you call to get parameters adjusted before it hits 185.
And the rapid response?
You call a rapid response or full code for any acute airway compromise, they lose their airway reflexes entirely, or if you witness a sudden precipitous drop in GCS, or a sudden pupil dilation, which means herniation is actively occurring.
Let's do a quick differential pattern recognition. If you see a sudden onset of symptoms, plus severe expressive aphasia, plus a known history of atrial fibrillation,
you immediately suspect an embolic ischemic stroke originating from the heart.
We talked about the aspirin trap. There's another critical care pearl in the outline regarding physical rehabilitation in the ICU. The footboard trap.
Oh, this is a classic board exam question and a very common bedside mistake made by well-meaning novice nurses.
Oh, is that?
Stroke patients with upper motor neuron lesions often develop severe spasticity and a condition called foot drop, where the weakened foot hangs downward. The logical instinct is to place a rigid, flat footboard at the end of the bed to prop the foot up at a 90-degree angle and prevent the drop.
Which seems entirely reasonable to maintain anatomical alignment.
It does, but anatomically it is exactly the wrong move. Because the upper motor neurons are damaged, the lower motor reflexes are uninhibited and hyperactive. Providing constant, hard sensory stimulation to the sole of the foot via a footboard triggers a continuous positive support reflex.
So it makes it worse.
It chemically and electrically commands the calf muscles to push back against the board, which dramatically increases plantar flexion and spasticity, making the foot drop much worse.
So what do you do instead?
You must use soft, high-top tennis shoes or specialized floating splints that maintain alignment without stimulating the sole of the foot.
Okay, let's synthesize this. Give me the intensivist thinking framework for the ischemic stroke.
The primary problem is an intravascular clot. The failing physiology is downstream tissue ischemia leading to cell death and secondary cerebral edema.
Immediate threat.
The immediate threat is permanent loss of neurological function and brainstem herniation from swelling.
And the interventions.
The primary interventions are systemic TPA, endovascular stent retrieval, and strict blood pressure management, either restrictive for TPA or permissive for salvage. Reassessment requires continuous NIHSS scoring and vigilant monitoring of the airway and level of consciousness.
So if you are that ICU nurse and you only remember 5 things about the ischemic pathway. 1. The core pathophysiology is ischemia leading to irreversible cell death within a 5-minute window, followed by massive cerebral edema.
Right.
2. The most critical assessment finding is establishing the exact time of symptom onset to determine intervention eligibility.
Crucial.
3. The most dangerous complications are hemorrhagic conversion if TPA protocols are violated and brainstem herniation peaking at 72 hours. 4. Your priority nursing actions are securing the airway, maintaining strict NPO status to prevent aspiration, and rushing the patient for a stat non-contrast CT.
Yep. And 5. The most important treatments are TPA within the 4.5-hour window or mechanical thrombectomy.
Perfect. Give me the 1-sentence clinical picture.
A patient experiences a sudden, painless onset of unilateral weakness and facial droop, often with a history of atrial fibrillation or severe atherosclerosis.
And your action phrase at the bedside. If you see a sudden focal neurological deficit, think time is brain, keep them NPO, and immediately facilitate non-contrast CT and a fingerstick glucose.
That is the complete blueprint for the 87%. That is the blocked pipe. But now we have to completely invert our thinking. We have to look at the burst pipe.
Section 2. You get the patient to the CT scanner. You run the non-contrast scan. The radiologist looks at the screen, and instead of dark, normal brain tissue, they see a massive, bright, white starburst in the center of the brain.
Yeah.
You are no longer dealing with a clot. TPA is off the table. You are dealing with a hemorrhagic stroke.
And the prognosis has just plummeted. Hemorrhagic strokes account for only 13% of all strokes, but they are devastating. The 30-day mortality rate for an intracerebral hemorrhage is between 40 and 80%. It is a catastrophic event.
Break down the 2 primary types of bleeds we see.
You have the intracerebral hemorrhage, which is a bleed directly into the deep brain parenchyma, commonly the basal ganglia, the thalamus, or the pons.
What causes that?
The absolute #1 cause of this is uncontrolled, long-standing hypertension. Years of high pressure weaken the small penetrating arteries until they simply rupture under the strain.
And the second type?
The second type is the subarachnoid hemorrhage, or SAH. This is bleeding into the cerebrospinal fluid space, the subarachnoid space that surrounds the surface of the brain.
And the culprit for the SAH is usually an aneurysm.
Specifically, a ruptured saccular or berry aneurysm, typically located in the bifurcations of the circle of Willis. We call aneurysms the silent killer because the pathophysiology is incredibly slow.
They just sit there for years.
Over decades, the sheer stress of arterial blood hitting the fork in a blood vessel causes the muscular wall of the artery to weaken and balloon outward, forming a thin-walled sac. The patient feels absolutely nothing. They have no symptoms. Until the exact millisecond that the paper-thin wall finally gives way and arterial blood blasts into the subarachnoid space.
So the trigger is the rupture. Let's talk about the physiological change, because we have to talk about the Monro-Kelly doctrine.
The Monro-Kelly doctrine is the foundational rule of neurocritical care. The adult skull is a rigid, inflexible bone box. Inside this closed box, you have 3 components: brain tissue, blood, and cerebrospinal fluid.
And there's no extra room.
None. The doctrine states that if the volume of any one of these components increases, one or both of the others must decrease, or the pressure will skyrocket.
So when an aneurysm bursts, you are violently injecting a massive volume of arterial blood into a box that has 0 capacity to expand.
Exactly. The physiological change is an instantaneous, massive spike in intracranial pressure. The compensatory mechanism is that the body tries to shunt cerebrospinal fluid down into the spinal cord to make room, and it tries to decrease cerebral blood volume by compressing the venous system.
But I'm guessing that fails quickly.
This compensation is overwhelmed almost immediately.
What does a decompensation look like?
2 profoundly destructive things happen. First, the physical mass effect. The expanding pool of blood acts like a rapidly growing tumor. It physically crushes the adjacent healthy brain tissue, shifting the midline of the brain and eventually forcing the brainstem down through the foramen magnum.
The opening at the base of the skull.
Right. This is uncal or tonsillar herniation, and it results in rapid respiratory and cardiac arrest.
And the second destructive mechanism. This one is specific to the subarachnoid space.
Yes, and this is where the intensive care management gets incredibly complex. When blood pools in the subarachnoid space, the red blood cells eventually begin to lyse, to break down.
And what happens when they break down?
As they degrade, they release highly toxic inflammatory metabolites directly onto the outer surface of the cerebral arteries. These toxins severely irritate the smooth muscle of the blood vessels, causing them to spasm aggressively.
This is cerebral vasospasm.
Yes. The arteries clamp down so tightly that they completely cut off blood flow to the downstream brain tissue.
Wait, so the bleed actually causes the blood vessels to constrict so much that it causes secondary ischemia. You have a hemorrhagic stroke that essentially triggers secondary ischemic stroke days later.
Exactly. It is a devastating 1-2 punch. The patient survives the initial bleeding event only to have their brains starved of oxygen a week later because the vessels are spasming in reaction to the old blood.
So clinically, what does that initial rupture look like? Ischemic strokes had the FAST acronym. What is the classic presentation of an SAH?
It is unmistakable. The patient will experience a sudden thunderclap headache. They will often describe it literally as the worst headache of my life. It hits maximum intensity within seconds.
Yeah, I vomit, right.
The spike in ICP instantly triggers projectile vomiting and a rapid, terrifying decline in the level of consciousness as the brainstem is compressed.
And you also see signs of meningeal irritation.
Yes, because blood is highly irritating to the meninges, the protective layer surrounding the brain and spinal cord. You will see nuchal rigidity, which is a profoundly stiff neck. The patient will forcefully resist any attempt to bend their neck forward. They will also experience severe photophobia, extreme sensitivity to light.
What are the late dangerous findings, the ones that mean we are losing the patient?
If the hemorrhage is located in the pons, the central control center of the brainstem, the presentation is catastrophic. The pons regulates basic life-sustaining functions. A massive pontine hemorrhage wipes out the reticular activating system and the autonomic pathways.
What does that look like on the bed?
You will see sudden, complete quadriplegia, pupils that are pinpoint or completely fixed and dilated, hyperthermia where their temperature spikes uncontrollably, deep coma, and usually rapid death.
Let's talk diagnostics. We know the non-contrast CT is the gold standard to visualize the blood. But the outline brings up a critical scenario. What if the patient has the thunderclap headache, the stiff neck, all the classic SAH symptoms, but the CT scan comes back negative for blood?
Sometimes tiny microbleeds don't show up on a CT immediately.
So the next step is traditionally a lumbar puncture, an LP, to draw cerebrospinal fluid and check it for red blood cells. But there's a massive flashing red warning light here.
This is a scenario where an action can kill a patient instantly. You absolutely do not perform a lumbar puncture if the patient is demonstrating clinical signs of severely elevated intracranial pressure, like a deteriorating LOC, unequal pupils, or papilledema on an eye exam.
Walk me through the physics of why an LP is fatal in that moment.
Think about the closed box. The pressure inside the skull is overwhelmingly high because of the expanding bleed. The brain is already being pushed downward toward the foramen magnum.
Okay, so it's under immense pressure.
If you insert a needle into the lower lumbar spine and draw out cerebrospinal fluid, you suddenly create a localized area of very low pressure at the bottom of the spinal canal. Fluid dynamics dictate that high pressure always moves toward low pressure.
Oh no.
The massive pressure in the skull will take the path of least resistance, and it will physically, forcefully suck the brainstem down through the base of the skull into the spinal canal. You will cause iatrogenic brain herniation and kill the patient on the table.
You must always confirm the ICP is manageable, usually via a negative CT, before proceeding with an LP.
Exactly.
Okay, let's translate this to the bedside. Priority nursing actions for a hemorrhagic stroke. Imagine you were receiving this patient from the ER.
First priority, secure the airway. If they're comatose, they have lost their gag reflex entirely. Because they are likely vomiting from the ICP spike, they will aspirate immediately, or their tongue will fall back and occlude the airway. You prepare for immediate endotracheal intubation.
Next priority.
Absolute, strict blood pressure control. This is the exact polar opposite of the ischemic stroke protocol. In an ischemic stroke, we allowed permissive hypertension to force blood past the clot.
But in a hemorrhagic stroke, the pipe has burst.
Right. If you allow the blood pressure to remain high, it acts like a pressure washer inside the brain parenchyma, violently expanding the hematoma and worsening the bleeding. You must initiate titratable IV antihypertensives again, labetalol or nicardipine, to aggressively keep the systolic blood pressure strictly below 160.
Then what?
Optimize venous drainage to lower the ICP. You elevate the head of the bed to exactly 30 degrees. And crucially, you ensure the patient's head is maintained in a perfectly neutral midline position.
Why does the head position matter so much?
If the patient's neck is twisted to the left or the right, or if it is severely flexed, it physically kinks the internal jugular veins in the neck.
Like stepping on a garden hose.
Yes. The brain relies on gravity and open jugular veins to drain venous blood back to the heart. If you kink the drain, the venous blood backs up into the skull, and the intracranial pressure spikes even higher. Head midline, always.
Let's discuss medications. We are obviously not giving TPA, aspirin, or heparin. What pharmacological tools do we actually use?
For a subarachnoid hemorrhage, we utilize a very specific calcium channel blocker called nimodipine.
What is the exact mechanism? Why this specific drug?
Remember the delayed threat of cerebral vasospasm? Those toxic red blood cell metabolites irritating the arteries and causing them to clamp down? Nimodipine is highly lipid-soluble, meaning it crosses the blood-brain barrier very efficiently.
And what does it do once it crosses?
It binds to the calcium channel, specifically in the smooth muscle of the cerebral arteries, preventing the influx of calcium. Without calcium, the muscle cannot contract. It selectively dilates the cerebral blood vessels, keeping them open and preventing that deadly secondary ischemic infarction.
But it's a calcium channel blocker, which means it will affect systemic hemodynamics. What are the hold parameters?
Because it causes vasodilation, it can drop the systemic blood pressure. As the nurse, you must check the vitals right before administration. You hold the nimodipine and immediately notify the provider if the patient's heart rate drops below 60, or if their systolic blood pressure drops below 90.
We manage the pressure, we manage the vasospasm, but how do we actually fix the physical rupture in the vessel?
Through invasive procedures, we have two primary surgical avenues, clipping or coiling. Surgical clipping requires a craniotomy. The neurosurgeon physically removes a piece of the skull, navigates through the brain tissue to the base of the aneurysm, and places a tiny, permanent titanium clip directly across the neck of the aneurysm.
It just pinches it off.
This pinches it off from the para-artery completely. The clip stays in the patient's brain for the rest of their life.
And endovascular coiling.
Coiling is much less invasive. It doesn't require opening the skull. It is an endovascular procedure using Guglielmi detachable coils, or GDC. Similar to the stent retriever, the interventionalist threads a microcatheter up from the groin directly into the dome of the aneurysm itself.
Then they put the coils in.
They then pack the aneurysm sac full of incredibly soft, microscopic platinum coils. These coils take up physical space and severely disrupt the blood flow inside the sac. This disruption triggers a massive localized clotting cascade. The aneurysm effectively thromboses itself solid, sealing it off from the inside.
So the vessel is secured. But what about the excess fluid and blood still trapped in the skull causing hydrocephalus and high ICP?
The neurosurgeon will place an external ventricular drain, or an EVD, also known as a ventriculostomy. They drill a small burr hole in the skull and pass a catheter directly into the lateral ventricles of the brain. This allows us to actively drain the excess cerebrospinal fluid and blood outward into a collection bag, instantly relieving the pressure inside the closed box.
Okay, here is the concept that is going to blow everyone's mind. I need to push back hard on this. We are talking about hyperdynamic therapy.
Wait.
We just established that chronic high blood pressure caused the aneurysm to burst in the first place.
Right.
We just established that the priority nursing action upon arrival is to aggressively drop the systolic below 160 to prevent rebleeding. But the intensive care protocols state that after the aneurysm is clipped or coiled, we intentionally hang 5V vasopressors like dopamine or norepinephrine to artificially jack the patient's blood pressure way up.
Yes, we do.
Why on earth are we inducing hypertension in a patient who just had a brain bleed?
Because the entire physiological landscape has changed. This is peak intensivist reasoning. Before the aneurysm is secured, high pressure is the enemy because it drives the bleeding. But once the clip or the coil is deployed, that weak spot is neutralized. The aneurysm is safe.
So what's the new enemy?
The new enemy is the delayed cerebral vasospasm, which, again, takes 6 to 10 days after the initial bleed.
The blood vessels are clamping down tightly in response to the toxic blood.
Exactly. The vessels downstream from the secured aneurysm are violently spasming, narrowing to a pinprick, starving the brain tissue. So how do we force oxygenated blood through a rigid, spastic, narrowed pipe?
You have to push harder.
We artificially increase the driving pressure and the fluid volume going through it. We utilize hyperdynamic therapy, historically known as Triple H therapy, hypervolemia, hemodilution, and induced hypertension.
So you pump them full of fluids.
We pump them full of IV fluids to expand their blood volume, and we use vasopressors to force their systemic blood pressure high enough to physically push blood past the spasm and keep the brain tissue alive.
So it is a complete 180-degree reversal in management. You aggressively drop the pressure to stop the bleed, you secure the vessel, and then you intentionally spike the pressure to defeat the secondary spasm.
It is a terrifying tightrope walk over an active volcano, and it requires constant minute-by-minute vigilance from the bedside nurse.
What about fluids? You mentioned hypervolemia?
Avoid dehydration at all costs. We use volume expansion with isotonic crystalloids or sometimes colloids like albumin post-clipping to maintain that hyperdynamic perfusion. You want their central venous pressure running high.
Let's run through the complications. We know them, but let's formalize them. Most likely and most dangerous.
The most likely immediate complication is rebleeding, which typically occurs within the first 24 hours before we can get them to the operating room. The mortality for a rebleed is catastrophic. The most dangerous delayed complication is the cerebral vasospasm, hitting that day 6 to 10 window.
If the patient is deteriorating, what is the ultimate physiological red flag?
You are watching for Cushing's triad.
Explain the mechanism behind Cushing's triad. What causes it?
Cushing's triad is the terminal physiological response to overwhelmingly high intracranial pressure compressing the brainstem. As the ICP rises so high that it begins to equal the mean arterial pressure, the brain realizes it is entirely starved of blood.
So what does the brain do?
In a desperate final attempt to perfuse itself, the sympathetic nervous system triggers a massive systemic vasoconstriction to drive the systolic blood pressure up. So you see a skyrocketing systolic pressure with a widening pulse pressure, meaning the gap between the systolic and diastolic numbers gets very large.
That's the first part. What about the heart rate?
The baroreceptors in the aortic arch sense this massive sudden spike in blood pressure. They panic, and they trigger a strong parasympathetic reflex via the vagus nerve to slow the heart down to protect the systemic vessels.
So the heart rate drops.
So, despite the high blood pressure, you see severe bradycardia. The heart rate drops into the 40s or 30s. Finally, the physical pressure crushing the medulla oblongata disrupts the respiratory centers, leading to altered, irregular, often Cheyne-Stokes respirations.
So Cushing's triad is widening pulse pressure, severe bradycardia, and irregular respirations. If you see that, what is happening?
Brain herniation is imminent or actively occurring. It is the ultimate late sign.
When do you bypass the provider and immediately call a code or initiate rapid emergency protocols?
If you witness a blown pupil, a pupil that becomes fully dilated, fixed, and non-reactive to light, that indicates the uncus of the temporal lobe is herniating downward and physically crushing the third cranial nerve.
What about posturing?
Or if the patient suddenly exhibits decorticate posturing, where the arms rigidly curl inward toward the core, or decerebrate posturing, where the arms rigidly extend outward and rotate. Both indicate severe, profound structural damage to the motor tracts in the brainstem.
Pattern recognition time. If you see X plus Y plus Z.
If you see a sudden, agonizingly severe headache, plus a stiff neck, plus photophobia and vomiting.
Think subarachnoid hemorrhage. Give me an ICU pearl for the exam, something that novice nurses miss.
The suctioning trap. Let's say you have an intubated patient with an unclipped, unsecured aneurysm. The wall of that aneurysm might be literally paper thin, currently being held together only by a tiny, fragile, unstable platelet plug.
Okay, so it's a ticking bomb.
If the nurse routinely goes in and performs vigorous endotracheal suctioning, or if the patient gags, bears down, or coughs violently, it causes a massive instantaneous spike in intrathoracic pressure,
Which translates directly up the jugular veins into the skull.
and pox the aneurysm. A routine episode of vigorous suctioning before the aneurysm is secured can cause it to instantly re-rupture and kill the patient in the bed.
That is terrifying.
You must keep the environment highly controlled, dim the lights, severely restrict visitors, aggressively aggressively manage pain and nausea, and minimize all noxious stimuli, including unnecessary suctioning.
Let's summarize the intensivist thinking for the hemorrhagic stroke.
The primary problem is active bleeding inside a closed, rigid box. The failing physiology is the destruction of brain tissue via mass effect and a massive spike in intracranial pressure.
The immediate threats.
Brainstem herniation and delayed cerebral vasospasm. The primary interventions are absolute blood pressure control initially, followed by surgical clipping or endovascular coiling, often accompanied by a ventriculostomy for pressure relief and subsequent hyperdynamic therapy.
And reassessment.
Reassessment requires continuous monitoring of the GCS, pupillary response, and exact ICP numbers from the monitor.
If you remember only 5 things about the hemorrhagic pathway. 1. The core pathophysiology is arterial bleeding creating a mass effect, immediately spiking the ICP and crushing healthy brain tissue.
Right.
2. The key assessment finding is the sudden onset of the worst headache of my life, accompanied by meningeal irritation and a rapidly altering level of consciousness. 3. The most dangerous complications are immediate brain herniation and delayed secondary ischemia from cerebral vasospasms. 4. Your priority nursing actions are securing the airway, implementing strict blood pressure control to keep the systolic below 160, maintaining a midline head position, and minimizing all physical stimulation.
And 5. The most important definitive treatments are surgical clipping or endovascular coiling, followed by nimodipine administration.
The one-sentence clinical picture. A patient suddenly clutches their head, screams about an agonizing thunderclap headache, begins vomiting aggressively, and rapidly loses consciousness.
And your action phrase. If you see a sudden agonizing headache with declining LOC, think hemorrhagic stroke, initiate immediate blood pressure control, and rush for a non-contrast CT.
Those are the 2 high-stakes pathways. But navigating the hyperacute phase in the ICU is merely the beginning of the war.
Which brings us to section 3. We have stabilized the patient. The clot is dissolved or the aneurysm is clipped. The alarms have finally stopped blaring, but as the sedation wears off, the reality sets in. The patient wakes up and they are fundamentally changed.
This is where clinical pattern recognition becomes vital for long-term rehabilitation, nursing care, and family education. You have to deeply understand the difference between right brain damage and left brain damage because they produce 2 entirely distinct behavioral and physical presentations.
Let's start with left brain damage. Because of the pyramidal crossing we discussed earlier, a stroke in the left hemisphere results in right hemiplegia paralysis or weakness on the right side of the body.
But the cognitive impact is what defines the care.
In the vast majority of the population, the left hemisphere is the dominant center for language, logic, and analytical processing. Therefore, left brain stroke patients almost universally suffer from some form of aphasia, a profound language deficit.
How does that affect their psychology and behavior?
They are painfully, acutely aware of their deficits.
Yeah,
their
right.
logic centers are intact, so they fully understand that they're paralyzed, and they fully understand that they cannot communicate.
That has to be devastating.
Because of this awareness, their behavior is usually very slow, very hesitant, and hyper-cautious. They are highly prone to severe depression, anxiety, and profound frustration because they understand exactly the magnitude of what they have lost.
And we contrast that with right brain damage, which creates almost the exact opposite psychological profile.
Right brain damage causes left hemiplegia, but the right hemisphere is the center for spatial perception, facial recognition, impulsivity, and executive judgment. These patients suffer from severe spatial perceptual deficits.
And they don't always realize it, do they?
And critically, they experience anosognosia. They often deny or actively minimize their physical problems. They literally do not realize they are impaired.
I want to use an analogy here to paint the picture of what this looks like on the rehab floor. Imagine you have 2 patients, both paralyzed on one side, sitting in wheelchairs.
The left brain stroke patient will sit in that wheelchair, stare at their paralyzed arm, fully understand that they cannot walk, and they will be terrified to even attempt to move without a physical therapist holding on to them. They are appropriately cautious.
But the right brain stroke patient, who is equally paralyzed, will confidently decide they want to go to the bathroom, try to stand up without locking the wheelchair wheels, and immediately fall face first onto the floor.
Exactly. Because their judgment and spatial awareness are destroyed, they believe they can still walk perfectly fine. The right brain stroke patient is an absolute massive fall risk.
They're impulsive.
They are incredibly impulsive, they lack all safety awareness, and you cannot trust their judgment for a second. You have to utilize bed alarms, constant supervision, and physical safeguards.
Let's dive deeper into the communication aspect, because dealing with aphasia is one of the most challenging aspects of bedside nursing. It is not just one uniform condition. The anatomy dictates the presentation.
We classify aphasia broadly into non-fluent and fluent categories. Let's look at Broca's aphasia, which is non-fluent or expressive aphasia.
What part of the brain is that?
The damage here is localized to the frontal lobe, specifically Broca's area, which handles a motor planning for speech. In these patients, their intellect and comprehension are completely intact. They know exactly what they want to say, but the physical motor pathway to articulate the words is broken.
So they might try to tell you, I really need to use the restroom right now, but the only words they can force out of their mouth are, restroom, go.
Yes, it requires immense, exhausting physical effort to speak. And because they can hear themselves failing to articulate their thoughts, they experience massive frustration and frequent emotional outbursts.
Now contrast that with Wernicke's aphasia.
Wernicke's is fluent or receptive aphasia. The damage is in the temporal lobe, the area responsible for processing and comprehending language. These patients can speak fluently.
It sounds normal.
The words flow out of their mouth effortlessly, with normal rhythm and inflection. But the words are completely disconnected from meaning. It is referred to as word salad.
They might point to a cup of water and say, you know that the smoodle pinkered the sideways? And they genuinely believe they just asked for a drink?
Exactly. And the tragic part is that they cannot comprehend what you are saying to them either. Because their comprehension is broken, they have absolutely no idea that they aren't making sense.
That has to be confusing for them.
They will often get angry at the nurse for not understanding their perfectly fluent, nonsensical sentences.
So what is the concrete nursing action for communicating with severe aphasia?
Environmental control and patience. Decrease all background noise. Turn off the TV. Present only one single thought or simple command at a time. Utilize visual cues, pointing, and communication boards with pictures.
And the big one.
And the absolute cardinal rule of neuronursing. Do not ever pretend you understand them if you don't. It is doubly patronizing. The patient will almost always realize you are faking it, and it permanently destroys the therapeutic trust.
What do you say instead?
Calmly and gently say, I am so sorry, I am having trouble understanding, and immediately offer a different method, like a pen and paper or a picture board.
Let's move to the visual and spatial deficits. We see a condition called homonymous hemianopsia. Break down that terminology.
Homo means same. Hemianopsia means half-blindness. It is blindness in the exact same half of the visual field in both eyes. If a patient has right-sided homonymous hemianopsia, they literally cannot see anything in the right half of their visual field.
It's just black.
It isn't just blurry, it simply does not exist in their constructed reality.
So if a nurse sets a food tray down directly in front of them,
The patient will only eat the food located on the left side of the plate. They will complain they are still hungry, completely ignoring the chicken and vegetables sitting on the right side. They will only shave the left side of their face.
how does our clinical action adapt to this over time?
It happens in two phases. Initially, in the acute ICU phase, when they are overwhelmed, you must approach them from their unaffected side. You place their food, their water, and their call light on the side they can actually see.
What if you approach from the blind side?
If you approach from the blind side, you will startle them violently, or they will simply ignore you. But later, as they transition into rehabilitation, the therapy completely flips.
We force them to look.
We begin placing items slightly into their blind field, forcing them to learn to consciously turn their head and actively scan the room to compensate for the blind spot.
Let's talk about basic physiological maintenance, GI and GU issues.
Constipation is universally the most common bowel problem post-stroke. It is a compounding issue driven by sudden immobility, weakened abdominal muscles making it difficult to bear down, and systemic dehydration because they cannot safely swallow thin liquids.
You have to proactively manage a bowel regimen.
But the major critical care pearl here, the thing that actually facilitates brain healing, revolves around nutrition.
Let's get into VBTF, volume-based tube feeding. Why is this protocol replacing traditional set-rate tube feeding for stroke patients?
Because traditional feeding stars the healing brain. Traditionally, a provider orders a tube feeding rate of, say, 50 milliliters an hour. But an active stroke patient in the step-down or rehab unit is constantly leaving the floor.
They're going to therapy.
They go to physical therapy, occupational therapy, a speech swallow study, or down for a follow-up CT scan. Every single time they leave the bed, the nurse pauses the tube feed pump to prevent aspiration during transport.
So the patient leaves for 3 hours of therapy, comes back, and the nurse restarts the pump at the ordered 50 milliliters an hour. But the patient just permanently missed 150 milliliters of vital nutrition that they will never get back.
Exactly. Retrospective studies showed these patients were consistently only receiving about 60% of their prescribed daily calories. And here's the physiology. The brain cannot heal neuroplastic pathways. It cannot build new synapses without massive amounts of metabolic energy.
So VBTF solves this.
VBTF solves this mathematical error. Instead of ordering a set hourly rate, the physician orders a total required volume over a 24-hour period. If the patient misses 3 hours of feeding for therapy, the nurse recalculates the remaining volume and increases the hourly rate for the rest of the day to catch up.
It ensures they get what they need.
It ensures they receive every single prescribed calorie. It forces the medical team to treat nutrition not as a dietary afterthought, but as a critical, titrated medication required for cellular healing.
That perfectly connects the bedside logistics back to the cellular pathophysiology. And that brings us full circle. I want to take a moment to connect all of this back to you, the listener.
It's all on you.
If you are that ICU nurse standing at the bedside, the sheer weight of the responsibility you hold is staggering. The intensivist might write the orders during rounds, but you are the one executing the critical thinking in real time, second by second. You are the one doing the hourly neurochecks at 3 a.m.
You're the one who has to notice that the right pupil is reacting just 1 millimeter more sluggishly than it was an hour ago.
Exactly. You are the one walking the terrifying blood pressure tightrope, advocating for permissive hypertension up to 215, but instantly intervening before it hits 221. You are the one fiercely guarding the airway and demanding the formal speech therapy swallow screen before anyone hands that patient a single pill.
You are the final line of defense between recovery and permanent, devastating disability or death. Spotting the subtle deterioration trend, the slowly rising heart rate, the slight widening of the pulse pressure, the transient slurring of a single word, that clinical vigilance is what saves the penumbra. It is what keeps the brain alive.
I want to leave you with a final thought, a concept from the deep rehabilitation phase that fundamentally changes how we view the brain. We spent this entire time talking about the fragility of the brain, the terrifying 5-minute window of ischemia, the catastrophic destruction of a hemorrhage.
It sounds so delicate.
But there is a therapy called constraint-induced movement therapy, or CIMT, that reveals a completely different reality.
It is the most raw, undeniable demonstration of neuroplasticity we have.
Imagine a patient who has survived a right brain stroke. They are left with a completely paralyzed left arm. In traditional therapy, you might just teach them how to adapt and live life using only their good right arm.
Right.
But in CIMT, the physical therapists take that patient's fully functional, perfectly good right arm, and they literally immobilize it. They strap it to their torso or put it in a massive restrictive mitt so the patient cannot use it for anything.
And then for hours a day, they force the patient to perform complex tasks, stacking blocks, eating, writing using only the paralyzed left arm.
It is an intensely brutal, endlessly frustrating psychological and physical process for the patient. They fail repeatedly. But here is the magic. By aggressively constraining the good arm, it forces the brain to realize it can no longer rely on the established surviving pathways.
It has to adapt.
The sheer metabolic, electrical, and physical demand of desperately trying to move that paralyzed limb forces the surviving neurons, adjacent to the stroke core, to physically grow new dendrites. They form entirely new synapses. The brain literally rewires a brand new architectural route around the dead tissue to regain motor control.
It definitively proves that the physiological fight does not end when the patient is discharged from the ICU. The brain's incredible capacity to heal, to physically remodel itself and find alternative routes, persists for years after the initial insult.
It is remarkably stubbornly resilient. The human brain will completely rebuild its own operating system to survive. But only if you, the elite critical care team, can maintain the perfusion, manage the pressure, and keep that tissue alive during those crucial high-stakes first few hours.
Time is brain. Protect the penumbra.
Thanks for diving deep with us. Keep questioning, keep learning, and we'll catch you on the next one.